Yes, so hello, my name is Paula Rodri guez Otero. I am a hematologist working at the University of Navarra in Pamplona, Spain, focused mostly in treatment of myeloma patients. So I would like to briefly present the updated analysis from the KarMMa-3 that was presented at the last ASH 2023 meeting. So this randomized study evaluated idecabtagene vicleucel or ide-cel versus standard regimens in a population of patients with triple-class exposed disease and relapsed refractory multiple myeloma. So in this updated analysis with a median follow-up of almost 31 months, so 30.9 months, ide-cel continued to show a significant improvement in the progression-free survival, with a median progression-free survival of 13.8 months versus 4.4 months and a hazard ratio of 0.49. So this is the final PFS analysis of this study. And in this updated presentation, we also showed the pre-planned interim overall survival analysis. So to understand the overall survival data, we need to go back to the study design. So in the KarMMa-3, eligible patients were randomized 2-to-1 to receive ide-cel or standard regimens. Patients that were allocated in the standard regimen arm received one of 5 different standard regimens until disease progression, and they were allowed to cross over to the ide-cel therapy after confirmation of disease progression. And so far, with the current follow-up, 82 patients had already crossed over from the standard regimens arm to the ide-cel arm, and 74 had already been infused with ide-cel. So if we analyze the overall survival data with a median follow-up of 30.9 months, the median overall survival in the ide-cel arm was 41.4 months versus 37.9 months in the standard regimen arm, with a hazard ratio of 1.01. Sorry. So to really understand this data, we need to again understand that close to 42% of the patients had already crossed over by month 15. A crossover occurred as early as by month 3 from randomization, with a median time from randomization to infusion of 8.1 months. So if we see the pre-specified sensitivity analysis adjusted for crossover, we show an overall survival benefit in favor of ide-cel, with a median of 41.4 months for ide-cel versus 23.4 months for the standard regimens arm, and a hazard ratio of 0.72. In addition, it is also important to understand that there is an imbalance in early overall survival events in the ide-cel arm that mostly occurred early in the first 6 months from randomization. And the majority of these patients that died early after randomization did never receive ide-cel therapy. So there were 30 patients in the ide-cel arm that died within the first 6 months from randomization, and 17 out of these 30 never received the study therapy. And the early death most commonly occurred in patients harboring high-risk features such as high-risk cytogenetic abnormalities, revised ISS stage 3, extramedullary disease, or high tumor burden. In addition, in the ide-cel arm, there was a lower use of effective bridging regimens, so the use of DPD and KD was lower in the ide-cel arm. There was also a lower dose intensity of the bridging therapy in the ide-cel arm, and a longer median time without any treatment in the ide-cel arm as compared to the standard regimen arm. And all these factors may explain the early deaths in these very high-risk patients. So if we do an exploratory analysis in the to analyze overall survival in patients who receive ide-cel therapy, we see a trend towards an overall survival benefit with a hazard ratio of 0.83 without adjusting for crossover. So regarding the safety profile with the extended follow-up, there were no new safety signals. So the safety profile is consistent with previous reports. No new cytokine release syndrome events, no new neurological complications. Importantly, no Parkinsonism and no second primary malignancies of T-cell origins were seen. So we believe that with this longer follow-up, in the KarMMa-3 study continues to demonstrate a significantly longer and clinically meaningful improvement in progression-free survival with ide-cel versus standard regimens in patients with triple-class exposed and early line relapse. The patient-centric design allowing for crossover confounds the overall survival interpretation. So 56% of the patients treated in the standard arm had already crossed over to receive ide-cel, and in the pre-specified analysis adjusting for crossover, there is an improvement in overall survival in favor of ide-cel. In addition, the bridging therapy was suboptimal in patients with high-risk features and rapidly progressive disease, and we believe that this highlights the importance of selecting the best bridging therapy to give to any CAR T-cell patient, and again, safety profile was manageable and consistent with previous studies. In addition to what I have just presented, there is another very relevant presentation from the same KarMMa-3 trial that is focusing on the evaluation of health-related quality of life. So in this phase 3 randomized study, quality of life was assessed using different questionnaires throughout the treatment in the 2 treatment arms. So the patients were asked to complete the questionnaires at baseline, so at the time of screening, the day of the CAR T-cell infusion or the first dose of a standard treatment, and every month from month to month 28, and then every 3 months. So the conclusions of this analysis focus on the health-related quality of life, shows that patients treated with ide-cel showed a significantly and meaningful improvement in myeloma-relevant symptoms, functioning, and overall health status compared with the standard regimens arm. And this improvement occurred sooner as compared to the standard regimens, and were sustained over more than 2 years, which is very relevant after a treatment that is given as a single infusion. So we believe that this further supports the benefit of ide-cel in this patient population.